So I'm going to talk mostly about respirators, although this is called equipment for aerosol transmissible diseases in healthcare. I'm an industrial hygienist with expertise in respiratory protection and exposure to hazardous aerosols, including infectious aerosols. So Bill talked about the hierarchy of controls, and it is a core principle for both patient and worker safety. I found that during the pandemic, using a source pathway receptor approach to discussing the hierarchy of controls is a good way to illustrate the different levels of controls and types. The priority has to be on minimizing aerosols at the source, and that means in minimizing the number of people in a shared space, using source controls like respirators, or eliminating sources by screening or testing. But if these are not effective at limiting the emission of hazardous aerosols, then controls that interrupt the pathway from source to receptor are the next option. And those are the ones that include ventilation, such as Dr. Bonfleth just discussed. The lowest priority are those that limit exposure at the receptor, and that is mostly personal protective equipment. And you need to do the first two first before you utilize respiratory protection. As was mentioned by other speakers, respirators work. The HICPAC work group suggests that surgical masks are equally capable at protecting people from infectious aerosols, but this is not true. You've seen plenty of data already to demonstrate this. There are numerous studies, many of which OSHA relied on when updating its respiratory protection standard, that demonstrate the efficacy of respirators in workplace settings, using workplace protection factor studies, for example. OSHA found that a negative pressure half face piece respirator, like an N95 filtering face piece respirator, is capable of reducing the external aerosol concentration by 10 times. So that's an assigned protection factor of 10. This is only if the respirator has been fit tested, however. There's no need for clinical studies of respirators in healthcare. I should note that the 95 refers only to the filter efficiency and not the overall protection of the respirator. And 95 refers to the efficiency when the filter is tested at the worst case conditions, which means that the filter will collect workplace aerosols with much higher efficiency than 95%. Surgical masks were originally worn to prevent emission of bacterial aerosols from the wearer, although randomized controlled trials have shown that they are not effective for this original purpose of preventing surgical wound infections. Today, they are also worn to prevent exposure to splashes, sprays, and droplets, although a face shield would be a much better choice for such exposures. Surgical masks do not prevent the emission or an inhalation of the small infectious aerosols that Drs. Milton and Tellier described. This table illustrates the difference between cloth and surgical masks and respirators. The left two columns show the degree of outward and inward leakage, where the lower the number, the better. The third column shows the filter efficiency, where the higher the number, the better. And the fourth column shows the breathing resistance, and the lower number means it's easier to breathe through. This table illustrates that N95 filtering face piece respirators have very efficient filters, and because they're designed to fit well in the face, very low inward and outward leakage. Surgical masks are highly variable. Some, like the 3M 1818, have good filter efficiency and can be fitted fairly well to limit inward and outward particle movement. But a procedure mask, on the other hand, has a less efficient filter and lots of inward and outward particle leakage. Cloth masks generally have very inefficient filters and have a lot of inward and outward leakage. So as demonstrated in the last slide, fit is important for limiting inward and outward leakage of particles, although good filter efficiency is also important. Numerous studies have demonstrated that it is impossible for people to determine whether they have a good fit without some form of testing. We are simply not very good at determining if a face piece is leaking on our face. That's why OSHA requires that workers are fit tested when they're required to wear a respirator. And fit testing is specific to the respirator manufacturer and model and size. While most healthcare organizations use qualitative fit testing, which depends on taste or smell to detect leaks, quantitative methods are better and are considered the gold standard. If each healthcare worker had been given an elastomeric respirator at the start of the pandemic, there would have been no supply issues and more respirators would have been available for other essential workers. This type of respirator has a lot of advantages. It's reusable, it's cleanable, it's easy to maintain. Every person can have their own. They are easy to fit test and check for that they actually fit when you put them on. They fit consistently over time, and while initially they're more expensive, they can result in considerable savings in a relatively short period of time. There are models without exhalation valves now and with speaking diaphragms that allow for better communication. NIOSH has been doing a lot of research on the use of elastomeric respirators in healthcare over the last 10 to 15 years, which CDC and HCPAC should encompass in the updated isolation precaution guidelines. Tight-fitting respirators can be uncomfortable over time, especially if they're worn for many hours. Moisture, pressure, sweat, and friction can contribute to skin irritation and damage and dermatitis. Some of these issues can be alleviated by receiving a well-fitting respirator and wearing the respirator correctly. In other words, it does not need to be tightened too small or tightened too closely to the face. As well, some respirator manufacturers have recommended skin protectants and barriers. Limiting the amount of time a respirator is worn and allowing for breaks can also minimize discomfort and skin problems. And there are other types of respirators, such as powered air purifying respirators, that are more comfortable and appropriate for long wear times, especially when other PPE adds to the overall burden. There have been a few studies suggesting that universal masking was effective at limiting healthcare-acquired infectious respiratory diseases, including but not limited to COVID-19. I've listed just a few of these here. It would be very appropriate for HCPAC to review the published studies, all of them, of universal masking and universal respirator use when updating the isolation precaution guidelines. Just as the use of gloves have become a core practice, the wearing of masks or respirators by all healthcare workers would be an appropriate core practice, particularly when there is increased incidence of infectious respiratory diseases. Instead of focusing on the minimal protections, HCPAC and CDC need to consider the science that supports the best and most feasible protections for healthcare workers and patients. And by best, I mean protective. So they need to consider protection and feasibility together. They need to include all stakeholders, including patients and healthcare workers, in their decisions. And they need to encourage the inclusion of workers and patients in policy making and implementation in each healthcare setting. And CDC needs to work hand in hand with OSHA in the development of guidelines that recognize and protect everyone from aerosol transmissible disease. In a very limited literature search I did in the last few days, I found numerous articles reviewing and discussing infection control guidelines and practices for the future. Rather than wasting time with flawed evidence reviews comparing respirators and surgical masks, I strongly urge CDC and HCPAC to seek input from scientists and infection prevention professionals across the world on lessons learned before and during the pandemic. Thank you.